Hello everyone, I am Dr. Ramesh Ingale, second year radiology resident of Dr. Ullas Patil Medical College and Hospital, Jalgaon. I am presenting the paper having topic Beyond the Panda, a radiologist perspective on the Wilson disease. Wilson disease is the genetic disorder of copper metabolism caused by the defect in the ATP7B, which is highly expressed in the liver and brain. The defect in this ATP7B, which lead to the accumulation of the copper into the blood, which subsequently lead to the deposition into the all the organs, but more accumulate in the liver and brain because ATP7B having high expression into the liver and brain. So multiple CT and MRI features are seen in the Wilson disease. So the aim of this study is to illustrate the magnetic resonance imaging of the brain finding in the clinically suspected cases of the Wilson disease to identify the atypical, lesser known, unusual MRI brain features of the Wilson disease. We present for clinically suspected cases of the Neuro Wilson disease in the age group of 13 to 18 years. All these patients were admitted in the Department of Pediatric with varied neuropsychiatric symptoms like tremors, dystonia, dysarthria. Detailed clinical history was obtained. Thorough clinical examination, including slit lab examination for KF ring, was done. Biochemical investigation, including serum ceruloplasmin, 24-hour urinary copper, liver function tests were ordered. Subsequently, MRI brain was performed on the 1.5 MR Siemens MR machine. Following MR sequences were acquired: axial T2, axial T2 flare, axial diffusion method images, axial EDC, axial SWA, axial 3D FSPGR. Now we'll see the cases with the typical neurosemic spectrum. Uh, the first case with a 60-year-old female patient with complaints of tremors in bilateral hands since 4 months. On examination, this wing beating tremor and dysarthria was present. On slit examination, bilateral KF ring was present. Serum ceruloplasmin is normal. 24-hour urine copper level is high. LFT was normal. So in the T2-weighted MR image A and axial flare MR image B shows the symmetrical hyperintensity in bilateral putamen with thin T2, hyperintensity in claustrum, bright claustrum sign, and bilateral thalami. Symmetrical hypointensity is noted in the bilateral globus pallidi. Axial SWMR image shows the symmetrical areas of the blooming in the bilateral globus pallidi. Axial T2-weighted MR image at the level of midbrain shows the hyperintense tegmentum with hypointense red nuclei, hypointense superior colliculi, and pars reticulata of the substantia nigra looks like ears and depicting the face of giant panda sign. Axial tutorated MR image at the level of pons show the hyperintense dorsal tegmentum with hypointense medial longitudinal fasciculus and central tegmentum tract looks like eyes. Hyperintense aqueduct opening into the fourth ventricle looks like nose and mouth, and hyperintense superior cerebellum peduncle looks like cheek depicting the face of miniature panda sign shown in the white box. So this is the case with typical neurologic features of Wilson disease. Now we'll see the case 2 with 18-year-old female patient having complaints of involuntary movement of bilateral upper limbs and history of multiple falls in the dark since 1 year. On examination, broad-based gait and dysdiadochokinesis was observed. On slit lamp examination, KF ring is seen bilateral eye. Serum copper level, ceruloplasmin level is low. 24-hour urinary copper level is high. LFT was normal. On T2-weighted MR image, A shows the symmetrical hyperintensity in bilateral caudate putamen and thalami with bright claustrum sign, symmetrical hyperintensity in the bilateral globus pallidi. Axial SWMR image shows the symmetrical areas of the blooming in the bilateral globus pallidi. Axial T2-weighted MR image at the level of midbrain C and at the level of pons D shows the face of giant panda sign and face of miniature panda sign respectively. This is the case of Wilson disease with a typical neuroimaging feature. The third case of 70-year-old male patient with complaints of difficulty in walking, history of recurrent falls since 2 months, difficulty in speaking and swallowing since 1 month. On examination, generalized hypertonia across all joints, short step gait, and cogwheel rigidity was present. Bilateral KF ring was present. Serum copper, ceruloplasmin is low. 24-hour urinary copper is high. LFT normal on ultrasound abdomen. Question ecotexture of liver with multiple defined hypoechoic areas within, giving a honeycombing pattern. And the axial tutorated MR image shows the symmetrical hyperintensity in bilateral caudate, peripheral parts of bilateral putamen and lateral parts of the bilateral thalami. Hypointensity is seen involving the central parts of the bilateral putamen. Axial tutorated MRB image B shows the symmetrical hypointensity in bilateral globus pallidi. Axial SWMR image shows symmetrical areas of the blooming in the bilateral globus pallidi and center part of the bilateral putamen. Axial T1 weighted MRI images D shows the no obvious abnormal hybridization in the bilateral basal ganglia. So this is the case of Wilson disease with typical neuroimaging feature. Now we'll see the Wilson disease with the atypical neuroimaging feature. 50-year-old male patient with complaints of involuntary movement of bilateral upper limbs followed by the lower limbs since last 3 months. Recently, there was a development of abnormal behavior and abnormal facial expression. Bilateral cave ring was present. Serum copper, ceruloplasmin level is low. 24-hour unit copper level is high. LFT is normal. A is the slit lamp examination, bilateral capering. Image B shows the symmetrical hyperintensity in bilateral cavity, putamen posterior limb of internal capsule, bilateral thalami, and showing bright claustrum sign. Symmetrical hypointensity is noted in bilateral globus pallidi. Axial SWI image shows the symmetrical areas of the blooming in the bilateral globus pallidi. Axial 228 MR image at the level of mid-brain and at the level of image pons shows the face of giant panda and face of miniature panda sign respectively. So axial deteriorated MR images A and C and axial deteriorated flare MR image B and D shows the bilateral symmetrical confluent white matter hyperintensities in the frontal, parietal, temporal lobes. Symmetrical deteriorated hyper intense and T2 flare hypointense subcortical cystic area seen in the bilateral, frontal, and temporal lobes. On diffusion and ADC show the focal areas of the diffusion restriction, bilateral frontal white matter. Axial T1 weighted and T2 weighted images show the cerebral atrophy. So this is the case of Wilson disease with the atypical neuroimaging features. So currently, following international recommendation of the recommendation, brain MRI utilizing classical sequences is a T1 T2 flare is essential for the every patient undergoing evaluation for the Wilson disease, forming the crucial component of the diagnostic protocol, that is Lipzig score. So this is the Lipzig score. So we conclude that the neuroimaging with MR brain is a valuable diagnostic tool in the patient of Wilson disease. Typical features of neuro Wilson disease: symmetrical hypointensity involving the putamen, thalami, caudate, bright claustrum sign, face of giant panda sign, face of miniature panda sign, symmetrical hypointensity and blooming in globus pallidus in all four cases. Are typical features like symmetrical white matter hyperintensities, subcortical cyst, focal white matter diffusion restriction, cerebral atrophy seen in all four cases. Other atypical features to look at: cerebral atrophy, hippocampal involvement due to hypointensity of bilateral basal ganglia in Wilson disease, such as iron deposition. Globus pallidus is the most commonly involved site seen in all four cases. So typically MRI brain features with white matter involvement and cystic changes are possible red flag signs for prolonged severe disease or rapid clinical progression, neurological deterioration, and poor response to the treatment. So radiologists thus play a vital role in identifying this atypical feature at the early stage, ensuring early initiation of the treatment. So Wilson disease should be considered as a differential for the leukoencephalopathy in a young patient with a progressive neurological feature. These are the references. Thank you.